So hello, everyone. So I think we'll get started. Thank you for joining our session. So my name is Jessica Jalbert of Regeneron, and I am very pleased to co-moderate with Montse Soriano Gabarro this session entitled The Thinning of the Blood, the Role of Anticoagulation in COVID-19. So before we get started, just a few housekeeping issues. So first of all, you'll probably have noticed that you're all currently on mute. That will persist throughout the session. However, we certainly want to hear from you if you have any questions. So if you have any questions, we encourage you to type them into the chat box. You don't need to wait until the end of the presenter's presentation to type those questions in. And so as I see someone has just essentially put in a question, so certainly don't wait until the presenter is done to ask your questions. We're essentially going to field them and order them and field them once the presentation is done. And then one last thing is that, if you're not able to attend this entire session, please note that the sessions are being recorded and they will be available after the meeting has ended. So with those housekeeping items covered, we'll go with our first speaker. And our first speaker is Albert Prats Uribe. He is from CSM and Dorms and the University of Oxford. Those are listed as his affiliation. And the title of his talk is entitled Heterogeneity and Temporal Variation in the Management of COVID-19, a multinational drug utilization study including 274,719 hospitalized patients from the US, China, Spain, and South Korea. So without further ado, the floor is yours.
Thank you, Jessica. It's a long title. Let me share my screen. I'm not sure I'm doing it right. Okay.
You're good. We can see your screen.
You can see my screen?
Yep.
Great. So then I'll start. Okay, I'm Albert from Oxford. Thank you for introducing me, and thank the organizers for letting me present my work here. I'm going to talk to you a little bit about the management of COVID-19 and the variation and heterogeneity during the pandemic. Here are my disclosures. These have been published as a paper, and there are like further disclosures in the paper, in the link. 1 second, because I think. Okay, now it works. You can find more. You can find the paper in this QR code, in the QR code in the bottom, and there's more information and much more data to explore in the green code and also in the paper. So yeah, let's start. Why do we need a drug utilization study for COVID-19? So at the start of the pandemic, as you know, there were like lots of medicines that were being repurposed on basis of in vitro antiviral activity. And this got to tweets and to social media, and also there was a lot also of observational studies not very well designed. And influential people hosted press conferences saying things like this.
Hydroxychloroquine? I'm taking it, hydroxychloroquine.
When?
Right now, yeah. A couple of weeks ago, I started taking it. Because I think it's good. I've heard a lot of good stories.
So at the end, the question if all these things got mirrored in real clinical practice. So for this study, what I'm going to show you and what we did is describe the use of drugs given to patients admitted to hospital with COVID-19. And for this, we use a federated approach and decentralized. Basically, there are different data sources, electronic health records and claims mostly, that are mapped to a common data model, OMO. And there's only one set of code that is sent to all the data sources, and they send back the results. But everything is open and available to the public. in every stage. So we got data from different parts of the world: South Korea, China, 2 hospitals in Spain, and several sites in the USA. And what we look at here is at the drug use on hospitalized patients from day 0 to day 30, and we defined that they had COVID-19 if they had a positive test or a COVID diagnosis during hospitalization or in the 3 weeks before hospitalization. So this is what we found. Probably as expected, a lot of heterogeneity. There were a lot of differences inside countries, across hospitals and across sites, and across countries. There was also a lot of difference in the management of COVID-19. But I think it's also more interesting to see what happened with time trends. And let's start with the infamous hydroxychloroquine for COVID. So in February, there was the first in vitro studies saying that there may be an effect of hydroxychloroquine inhibiting coronavirus or chloroquine. And as you can see here in the x-axis, we have the months of 2020, and the y-axis, there's the percentage of patients hospitalized that got this drug in any moment of the hospitalization. So in February, the use was medium, but then in March, a lot of new evidence started coming out, with hydroxychloroquine being useful in vitro. Then some maybe not so good observational studies showing effectiveness of hydroxychloroquine. There was an FDA emergency authorization. And as I said, there were a lot of influential people making certain declarations in social media like this.
Estou tomando aqui a terceira dose da hidroxicloroquina.
So as you can see, March is the peak of use of hydroxychloroquine, with in some cases more than 75% of patients admitted to hospital were taking hydroxychloroquine. But then we move into April, and there's the first reports of that probably this is not so good, and even less considering that it was given with azithromycin, and this could have serious safety issues. And the use started going down, as you can see. And further into May, there was an observational study saying that hydroxychloroquine was not effective in these patients. Solidarity trial stopped the hydroxychloroquine arm. And finally, in June, we got proper confirmation in a trial that this was hydroxychloroquine was of no use for hospitalized patients. And then the use of hydroxychloroquine is almost zero in every site, and stays zero for the whole year. But let's see what happened with the drugs that actually work, like dexamethasone. So here in May, we have the first results of the recovery trial that were these.
Sickest patients who were requiring ventilators, for example, we could reduce the risk of death by 1/3.
So as you see before the trial, there's low use of dexamethasone among hospitalized patients. But after the results of the trial, we got that almost every site gets to use hospitalized. More than half of the patient gets to use dexamethasone. Most of half of the patients get dexamethasone. And if we look at the other corticosteroids, this would go almost to more than 75% or almost 100%. And I know this is this breakout room is about anticoagulation coagulation. So I'm showing you the results for enoxaparin, where we see that for most of the pandemic, it was widely used enoxaparin, like more than 50%. In hospitalized patients, and the ones that were not using enoxaparin, probably they were using another anticoagulant like heparin, that was also pretty consistent throughout the pandemic. So to conclude, there was a lot of heterogeneity on the medicines used at the start of the pandemic. And the first months were driven by in vitro results and maybe not so good quality observational research. But once good quality research, both observational and trials, came out, quickly changed the trends, and we started doing what we know it's effective and stopped doing what we know it's not effective and probably not safe. So that's it. I want to thank you, all my co-authors of the paper, and all the people that contributed to this paper, and all the patients and families that suffered COVID-19 and contributed with their data to this paper. Thank you for your attention, and here you can find more both in the paper and in the Data Explorer.
Great, thank you, Albert, for such a nice presentation. You're definitely a master at using those animations. So thank you for that. So I'm opening the floor up for questions from the audience. Again, please type your questions in the chat box, and we'll ask them to Albert. And so while we're waiting for your questions to come in, I was going to ask you a question regarding the different data sets that you used for your study. So you had, different data sets from the US, from Spain, from, I don't remember, all the different places in the world that you had data sets from. But I wanted to know essentially whether or not you had any information on whether or not the patients were using any of these medications prior to hospitalization. So for something like hydroxychloroquine, that's unlikely to be used, very regularly by some patients within the population, right? I think the only indication is malaria. But for something like dexamethasone, that might be a very different situation. So I was wondering if you could tell us a little bit more about that.
Yes, what we did here is, instead of looking at the individual level, what we had was the use of these drugs in the previous year and in the previous 30 days, I think, and in the previous time. So we kind of compared also the percentage of patients that use it after hospitalization and before hospitalization. So yeah, this data is available, and yeah, of course, these ones are the ones that they're different. The ones that there are no differences, they're in the paper in the additional data, but there's no, we haven't explained much more about it yet.
Okay, thank you. I was going to ask you also regarding, so I think you did a really great job at showing essentially the differences for why we were seeing differences in terms of the time trends, right? With some politicians making some pretty strong statements regarding, for example, hydrochloroquine. But I was wondering if you had any insights as to essentially why we were seeing still, some variation from country to country. Are there differences in guidelines, for example, for how dexamethasone is used versus and hydrochloroquine across a different country? And is that basically, leading to some of the heterogeneity that you're seeing?
Yeah, I think when we look at the still picture, I think the main sort of difference is how many months of follow-up we have, because things have changed so much. But when we look at trends, and we do see differences between countries, between sites, most of the things, especially at the start of the pandemic, were very hospital dependent, I think. So most hospitals were making their own treatment plans and their own guidelines, because there was no guidelines available, right? So I think that's the main source of heterogeneity here, and also by countries. There are some countries that were doing things like South Korea were doing things quite differently than Spain and the US probably.
Okay, excellent. Thank you. One last question. Are you planning to extend? I saw that the data you were showing are up until December. Are you planning to extend this work and include? I know that there are other medications that you've looked at that are not included in this short presentation. But are you also going to be adding additional medications and lengthening the study period to look at trends into 2021?
So no, for now it's just until December, but this is a rolling study. So if you go to the Data Explorer, you can see data. I think I don't know how long because I haven't been following up, but there's data of 2021 probably, and there will be data if like sites keep running and keep sharing wanting to share the data. Yeah.
Okay, so maybe an idea for the future,
Yeah.
for a future study. All right, well, thank you. I think we're at time, and I think I will pass it. Thank you very much for your interesting presentation, and then I will pass it to Montse to introduce our next speaker.
Thank you, Jessica, and thank you, Albert. So I'm very pleased to introduce the next speaker. This is Benjamin Bates. Benjamin is a postdoctoral fellow in cancer epidemiology at the Center for Pharmacoepidemiology and Treatment Science at Rutgers University. So I'm guessing today Benjamin is not going to be telling us about cancer, but I think he's going to take us back to COVID, probably an extra task during your work, routine work or normal work at Rutgers. So happy to have you with us, and the floor is yours. I think you will be presenting your slides.
Great. Thank you so much. Let me share my slides. And now can you see the proper slides? Yeah?
Mm-hmm.
Okay, great. Well, thank you guys. And actually, I think that this is a great connection going from Albert's study here as he left off with anticoagulant utilization. So what our study looked at the use of anticoagulants among patients with COVID-19. And so specifically it's early in the pandemic, it was noted there was a high incidence of both venous and arterial clots among these COVID-19 patients. And this was occurring even though patients were receiving the typical kind of low dose anticoagulant for when you're hospitalized. But in addition, there was this concern that these patients could also be at increased bleeding potential too. So early studies in the pandemic noted that there were pretty significant benefits in terms of time, going into the ICU, being intubated, even death. But then later studies began to indicate there might also be this increased risk of bleeding among these patients who are receiving these anticoagulants, which then opens up the question of how it's actually, who should use it and so forth. And then in addition, was also mentioned, is that hospitals were creating their own protocols, and studies have shown that they're even within the US among academic institutions, protocols varied. And so then the question here is, how are anticoagulants actually being used among COVID-19 patients in the US? And so our specific objectives here were to describe, one, the admission type, and then also the dose of the anticoagulant received, and then to assess the variation at time of admission over time between institutions in the US. And so specifically, we used a data source called National COVID Cohort Collaborative, known as N3C for short. So this was initially designed in order to answer some of these questions about COVID-19. And so essentially, it's primarily academic large institutions in the US that provide EHR level data to N3C. And there the data is harmonized, placed into OMOP format, and then it's available for researchers with the DUA. And so our cohort definition is that these individuals had to be hospitalized between March 1st, 2020 and May 15th, 2021. They had to either be COVID-19 positive on the PCR or by diagnosis. And this had to occur within 7 days prior to the hospitalization and 2 days within the hospitalization. They had to be hospitalized for 3 days. And then they had to receive an anticoagulant at the time of admission. Then the exclusion were if they were less than 18 years of age. So the specific anticoagulants that we looked at were enoxaparin, heparin, and then DOACs, which specifically in this case were apixaban and rivaroxaban. And so based on a daily dosage, we categorized them into standard prophylaxis, the high prophylaxis, and the treatment dose anticoagulant. And specifically how we categorized them were enoxaparin into standard could be categorized into standard, high prophylaxis, or treatment dose. And then heparin could only be standard prophylaxis and treatment dose, and a DOAC, essentially, if you received this medicine, you were considered to be on the treatment dose. And then, of course, BMI and kidney function could influence for enoxaparin whether they're categorized within the standard, high, or treatment dose. And so because we needed high quality drug data, we had to review each of the institutions within N3C to ensure that we were able to remove duplicate drug exposure records, that we're able to understand the dose of enoxaparin and heparin, that we have the initial start and end date of this anticoagulant, and that these dates fall within the time of the hospitalization. Then finally, that the exposure to the start dates needs to be before the end date, before or equal to the end date. And so then patient characteristics that at least I present here are the demographics, certain comorbidities, the physical exam, and then laboratory data. The analysis that we used is first describing the types and levels of anticoagulation that they received at admission. And then we summarize the demographics, the comorbidities, and admission characteristics by the type of anticoagulation, specifically standard prophylaxis versus high prophylaxis and treatment dose, then describe changes in the intensity of anticoagulation over time and between institutions. So our results are that among the 48 institutions, we found that only 6 of these institutions met our requirements that I laid out previously. This included 17,582 individuals. And so specifically these people have COVID-19 and then where they received a categorizable anticoagulant during the hospitalization. So enoxaparin was the most commonly prescribed, and then heparin, and then a DOAC. In terms of the kind of strength of anticoagulant received, the standard prophylaxis was about 73%, then high prophylaxis, and then treatment dose. Some of the baseline comorbidities, or I guess demographics, is that what we see is that we see the standard prophylaxis on the left side, and then the high prophylaxis or treatment on the right side. And what we see here is that the high prophylaxis and treatment, the age is slightly higher, 65 versus 61, although the kind of range overlaps though. And some other specific points, I guess, about the comorbidities are that the high prophylaxis and treatment had higher frequency of diabetes, 31 to 27, more heart failure, 17 to 9, and more cancer, 12 to 9.6. And then as well as the D-dimer was also greater than 1,000 among individuals on a high prophylaxis more commonly. And so then in terms of anticoagulant strength received over time, essentially this shows that starting from March of 2020 over until April of 2021, what we see, and then the red line shows a standard prophylaxis, and then the lower line shows the high prophylaxis or treatment. And so then I'm going to walk you through a little bit more specific. So in March of 2020, among the people who were on high or treatment dose, 12% were on high prophylaxis, 11% were on treatment dose. By June of 2020, which was the peak of the kind of the use of the high prophylaxis and treatment dose, it was 24% high prophylaxis, 20% treatment dose. And then in April 2021, it was about 14% high prophylaxis, 14% treatment dose. And so essentially we see that there was a kind of a quicker uptake of the high prophylaxis and treatment dose. It plateaus until about February, and then there's a slight downtrend between March and April that doesn't quite meet the initial March of 2020 baseline. In terms of patients receiving high prophylaxis and treatment dose anticoagulant by institution, what we see here is that there does appear to be variation among institutions. That, for instance, institution number 1, it was about slightly more than 20% of people were on high prophylaxis or treatment dose, whereas institution number 6, about 50% were on high prophylaxis or treatment dose, and then the other 50% or so were on standard prophylaxis. In terms of D-dimer, we also see that there is some heterogeneity here among the institutions, although there is the 95th percentile confidence interval does have overlap, but we still do see a general trend about certain institutions that have patients on the treatment dose or high prophylaxis anticoagulant have a higher number of people with the D-dimer greater than 1,000. And essentially the D-dimer greater than 1,000 it can be used as a prognostic marker as well as the signs of the COVID-19 severity. And so discussion about this is that there were more comorbidities and higher D-dimers among people who received the high prophylaxis and treatment anticoagulant. Potentially this could show differences of hospital protocol, more severe COVID-19 among these individuals, and then, or also they also developed the venous thromboembolism where the standard would be to treat them with the treatment dose anticoagulant. The variation, and there is variation in anticoagulant use over time. This could potentially reflect clinical practice change based off of publications that have come out showing the increased benefit and then maybe some risks and a little bit more nuanced approach. Between hospitals, this could reflect differences in the hospital anticoagulant protocols between each of these institutions. Do you put them on a higher anticoagulant because they have more comorbidities or certain comorbidities, or D-dimers higher, or just because they have COVID-19? And then, so some limitations of our study is that of the 48 institutions available to us, we only included 6 in this study. That we did have to make certain assumptions about the anticoagulant, such as that we're capturing these anticoagulants, that we're able to rely on the BMI and kidney function, which are essentially used for the categorizing of the enoxaparin. And then of course that certain comorbidities maybe we're not actually able to capture just because the data is not present. They might not have been recorded in the EHR, and then potentially missing laboratory results of whether the lab results weren't provided or or maybe that they didn't have it drawn on the day that we assessed. So in terms of our conclusion, essentially that the use of high dose prophylaxis or treatment dose did change over time and varied among institutions. And then also that approximately 30% of patients received high dose prophylaxis or treatment dose, and these patients did have differences of frequency of comorbidities with the D-dimer greater than 1,000 compared to standard dose. And then finally, I think this opens up the question about more research that could be able to look at the risks and the benefits of these high intensity anticoagulation among the general people who are admitted with COVID-19, as well as among high risk populations for bleeding or significant COVID-19. Thank you.
Thank you, Benjamin. That was a very nice presentation and very, very well developed. Thank you. We have time for questions. I think the easiest would be if anyone has a question to type it on the chat and I will read it for you. In the meantime, I already had a few questions myself, but I wouldn't want to be the only one talking. So hopefully I will see something coming on the chat. But having worked myself a little bit on anticoagulation and thinking primarily on novel anticoagulants, I was interested that you used the term critically ill at the beginning of your presentation. Did you look at how this is defined, especially for the use of rivaroxaban and the other novel anticoagulant that you had in your study? So did you try to characterize whether they met the criteria for critically ill?
Great question. And so this was our initial approach at categorizing and describing what we're seeing in the data. And so the next steps are about further assessing the cohort about the critical illness and so forth. And in terms of with critical illness, I guess typically I consider that there are people who are in the ICU who are intubated, although that definition, of course, could be varied, especially with COVID-19 as well.
Mm-hmm. So there was no standard definition that you were able to apply, I guess.
Well, so in this case, what we attempted to do was assess of categorizing patients who are hospitalized and then into different levels of anticoagulation, kind of the strength of it. We didn't attempt to take into account specifically, apart from the D-dimer greater than 1,000, but that'll be our next steps, will be about better assessing these types of the patients and their characteristics.
Somebody asked a question and I can recognize this is Frederick. Hello, Frederick. The question is the following. You may be able to see that yourself. Do you have information on how long the patients were treated and if they had treatment after this discharge?
Yeah, so great question. So in terms of the data, it's available within an N3C. So, we've created this cohort of patients who receive initial anticoagulant at the time of admission, and that's what I described here. But then further steps could be about assessing the anticoagulant use throughout the hospitalization. Are there varying levels of intensity that occur? Patients at discharge, if they were on a high prophylaxis, are they likely to be discharged on a treatment dose anticoagulant at discharge? So all of those are certainly relevant questions, which the data source potentially could be able to use to explain, or better provide evidence for at least.
And maybe I will follow up a little bit on that question. So as I understand, there is increasing publications and reports on the use of novel anticoagulants post-discharge. And a big question is the dose, obviously the benefit risk assessment and the duration of treatment. Do you think that this type of network that you have used, the 6 hospitals or maybe a larger set of hospitals, could actually be a good source for evaluating this type of question? It seems to be a big gap right now in the field of COVID-19.
And I don't want to give the definitive answer to this specifically, but I guess at least some insight, some points at least that I can put there is that this cohort or this data source is particularly good about assessing if you're hospitalized with COVID-19. We're able to assess you during that hospitalization. After discharge, it opens up the question, do they continue to follow up at that institution? And if so, you could have data on it. But if this is a group of people who are hospitalized at hospital A, but then live in a different state, you're not going to have data on them, continuing, at least at this point in time, with the data source.
And maybe then one final question, at least from my side, in terms of exactly the type of institutions that you included in this study. Are these, and I noticed in one of the graphs, institution number 6 seemed to be behaving slightly differently in one of the aspects that you were evaluating. Can you tell us a little bit about, for example, what was institution number 6? What type of hospital setting was that? And to tell us a little bit also about the populations that are served by these type of hospitals?
Yeah, definitely important. So in terms of the healthcare systems that are involved, they're typically academic institutions. These academic institutions might be submitting data from just their institution, or it could also be a big network of that they include the large academic center, but then also the surrounding community hospitals as well. And so there's definitely some systems that are larger than others. And I don't have the specific, where it's located or which institution it is, but theoretically of the 40 institutions initially assessed, they're throughout the United States, from coast to coast.
Well, thank you very much. I don't see any other questions on the chat, and I believe we are doing quite well with time. I guess Jessica will be introducing the next speaker. And thank you very much, Benjamin, for this great presentation. Thank you.
Thank you.
Thank you. Hello again. So our next speaker is Christopher Wrench. Christopher Wrench comes to us from the London School for Health and Tropical Medicine, as well as Yale. And he will be talking about the safety and effectiveness of prophylactic anticoagulation for prevention of COVID-19 mortality, a nationwide cohort study of hospitalized patients in the US. So I confirm that we can see your slides, Christopher.
Excellent. Thank you very much, Jessica, Monty, and the organizing committee for inviting us to share this work. My talk follows on extremely nicely from Benjamin's previous talk, almost as this almost as though this order was planned. Benjamin brilliantly covered the utilization of anticoagulants in hospitalized patients in the US, and I will continue that story and share what we found in terms of the safety and effectiveness of initiating anticoagulation in hospitalized patients. I have no conflicts to report, and this work was supported by the NIAAA and the VA HSR&D. So the US Department of Veterans Affairs, or the VA for short, is the largest integrated healthcare system in the United States. And it is one of the few sources of electronic health record data globally of its size, with the necessary outpatient and inpatient records, pharmacy fill and refills, death records, and linked SARS-CoV-2 testing to perform high-quality RWE studies. Early in the pandemic, the VA jumped to action and began investigating a number of different therapies, including hydroxychloroquine, remdesivir, corticosteroids, among others. In this talk, I will overview our study assessing the safety and effectiveness of anticoagulants in patients admitted to hospital with COVID-19. So I am here presenting on behalf of many colleagues, without whom this work would have not been possible. Also to note, this work has been published in the BMJ in February this year, and I'm pleased to share that we have received overall positive reviews in the press and public. So first, a quick background, almost repeating itself from the previous talks. But just to say that we know that deaths from COVID-19 have been partially attributed to the formation of blood clots that have led to more serious thromboembolic events, hence why this session was organized. And so anticoagulants may be particularly effective for treating patients with COVID-19 due to their prevention of blood clots, but also because they possess antiviral and potentially anti-inflammatory properties. However, there is limited data-driven evidence that directly addresses whether there is benefit from initiating low-dose anticoagulation therapy in patients with COVID-19. So we set out to evaluate whether early initiation of prophylactic anticoagulation compared with no anticoagulation was associated with decreased risk of death amongst patients admitted to hospital with COVID-19. How did we do that? We identified all patients hospitalized in the VA between March 1st and July 31st, 2020, who had a positive test result on or within 14 days prior to hospital admission. We excluded patients who were on anticoagulation prior to hospitalization, as well as those who died or discharged within 24 hours of admission. Thus, all patients in the primary analysis survived for at least 1 day. We then split the 4297 patients in the cohort into two groups: those who did and those who did not receive prophylactic anticoagulation within 24 hours of hospital admission. We developed an algorithm to classify all anticoagulant pharmacy records as either low dose, i.e. prophylactic, or full, i.e. therapeutic, shown in this table. And even though we spent a considerable amount of time developing this very complicated algorithm to separate these all the pharmacy fill records out, in the end, over 99% of all patients who received prophylactic anticoagulation received either subcutaneous heparin or the low molecular weight heparin enoxaparin. We developed a model to estimate the probability of receiving prophylactic anticoagulation, which included a wide range of personal and clinical covariates, including pre-existing health conditions, acute laboratory measures, and vital signs at admission. Using inverse probability of treatment weighting, we followed patients up for three outcomes: 30-day mortality, deaths occurring in hospital only, and initiation of therapeutic anticoagulation, which was a proxy for clinical deterioration, including thromboembolic events. So if we focus on the top two rows for the outcome of 30-day mortality, we see that 3627, or around 84% of patients in this cohort at this time period, received prophylactic anticoagulation. Of these, 513 died within 30 days, compared to 109 deaths amongst those who received no anticoagulation. Moving to the right, the cumulative incidence of mortality at 30 days was 14.3% for those who received the therapy and 18.7% for those who did not, resulting in a hazard ratio of 0.73. Looking down the table, we find similar relative associations with inpatient mortality and initiating therapeutic anticoagulation. Here is the weighted Kaplan-Meier curve for the outcome of 30-day mortality. We can see that the group who received prophylactic anticoagulation, shown in the dashed orange line, had a less pronounced probability of death quite early on, which compared to those who received no anticoagulation, shown in the solid purple line, persisted over the 30 days. In secondary and post-hoc analyses arising from peer review, we found no difference in the effects when looking at sub-Q heparin and enoxaparin separately. We did find some evidence that benefit was greater in patients not transferred to the ICU within 24 hours of hospital admission. And in a safety analysis, receipt of prophylactic anticoagulation was not associated with increased risk of a serious bleeding event. We performed a number of sensitivity analyses that are detailed in the paper, including quantitative bias analysis, propensity score capping, robust variance and stabilized weighting, expanding the exposure ascertainment window to 48 hours, and excluding the relatively few patients who were prescribed DOACs. I unfortunately do not have enough time to cover the results of each of these sensitivity analyses today, but the too long didn't read version is results persisted throughout all of them. So how do our findings fit with other evidence? Here's a table of key existing evidence as of a week and a half or so ago that I've been able to find at distinct clinical stages of infection, including the probability of death given a positive test, probability of death given hospitalization, and probability of death given intensive care. Previous RWE studies comparing prophylactic or therapeutic anticoagulants to no anticoagulants have found very strong benefit, though most are limited in sample size and to small healthcare systems, and many have not adequately addressed the potential for confounding by indication or indeed contraindication. In terms of trial evidence, the largest trial thus far on anticoagulation, called ACTIV-4, has just reported out earlier this month. They compared therapeutic doses to prophylactic doses and found evidence of a protective effect in non-critically ill patients, but not in critically ill patients. So taken in the round, these estimates show approximately a 20 to 30% benefit from early initiation of anticoagulation, particularly in non-critically ill patients, amongst patients admitted to hospital with COVID-19. Thanks again for inviting us to share these exciting results. Here are the paper DOI, and I will pop that into the chat as well as my contact information for any further queries. And I look forward to the discussion. Thank you.
Great, thank you so much, Christopher. That was a very, very nice work, very clearly presented and organized. So I invite our attendees to, pop some questions in again in the chat box, and then while we're waiting though for people to ask their questions, I'm going to start with one. So I guess one thing I wanted to ask is, regarding the patients who did not receive any anticoagulation. So did you, so I guess one concern would be that they might either be receiving other treatments, right? Or were they potentially receiving, treatment or therapeutic, anticoagulants? Could that be a possibility? And then would you be then also worried, potentially about, channeling essentially that the patients who are the sickest, if they're not on anticoagulants or therapeutic levels of anticoagulants, that might be at play?
Yeah, really good questions. And we spent a lot of time thinking about that. Who are the 16% that weren't prescribed prophylactic anticoagulants? I should say we dealt with a lot of it through inclusion-exclusion criteria. So we excluded people who were on therapeutic doses of anticoagulation prior to hitting the hospital. Because it's very likely that if you were on chronic anticoags for other indications, for any indication, as soon as you hit the hospital, if it's not contraindicated, you would continue such a therapy. And so we made sure to exclude those that were already receiving therapeutic, as they wouldn't be eligible to receive prophylactic anticoagulation. And then in terms of the channeling, it's a really good question. We dove into these individuals to see, their disease severity, whether they were on other drugs that were at the time when we published this. The most promising, I believe, were remdesivir and dexamethasone. And so we made sure to pull those. Dexamethasone, as we know, is more effective towards the end amongst the very sick. So we didn't get a lot of feedback there in terms of our exposure ascertainment window, which was in the first 24 hours. But remdesivir, there was some variation in between the two groups, and we made sure to balance that by including it in the IPTW weighting.
Okay, excellent, thank you. Seeing that there are no questions that have yet popped up on the chat, I will ask another one. It might be a bit of a difficult one to answer, but a lot of things essentially might happen after the first, let's say, 24 hours after the patient is admitted, right? And so, the patient's, health could deteriorate. They could be put on a number of other medications. So I'm wondering. I wanted to ask your thoughts about that. I'll just leave it at that. I know it's a big question.
It's the most frequent question that I get, so I'm well prepared for that one. So yes, of course, things can happen after the first 24 hours. We have in increasing the exposure ascertainment window from 24 to 48 hours. Whoop-de-doo, there's still plenty of weeks on average of people changing their therapies within hospital potentially. Ideally, one would want to employ methods that deal with such time-varying exposures, but what comes with that is the need to adjust for time-varying confounders. And then the data we have the data in the VA, unfortunately, do not have a time-updated, are not able to account for such time-updated confounding. Because any diagnosis, for example, that is given to a patient, and this is happening in most healthcare systems, in most EHR databases, any diagnoses that occur during a hospitalization, other than the primary, are kind of assessed at a single time point, and it's usually when they were discharged. So being able to determine what was actually happening during the course of the hospitalization becomes very difficult. Now, that's not to say you can't throw what data you do have into a marginal structural model and obtain an estimate. And many of my colleagues have done that, and we cited them in the presentation, but we just didn't feel comfortable enough with doing that because we knew important things like diagnoses, vitals, those things are kind of stored in either separate databases or not really time updated in a way that we can appropriately count for all the time varying confounding.
Okay, understood, thank you. Perfect. So one last question, one from our audience this time. So where essentially the question is, was there an analysis by age? So basically stratifying, I guess by age versus younger ages versus the elderly. And then did you also consider time? So, what is apparently, so perhaps before and after the vaccination started for especially the older patient population?
Really important questions. We can't comment on that from our analysis because our data set only went up through the end of July 2020. So vaccinations weren't present at that time, but this is a very important, as well as any long hauler and all the other conversations that have been coming up with the previous previous presentations around, potentially prescribing anticoagulants as people are discharged or after their acute infection, TBD on that. And I'm really looking forward to evidence on those questions.
Another idea for a future study. So on that note, Christopher, thank you so much for your time and for your great presentation. And I will be passing it back to Montse, who will introduce our next speaker and moderate the next session.
Thank you. And our next speaker is also going to be telling us about another study in a US population. This is Kai-Hua Liang, who currently works at Pfizer and prior to that was senior epidemiologist at Optum. And the title of her presentation is Anticoagulants and All-Cause Mortality Among Hospitalized COVID-19 Patients. And as I said, I believe this is still another study in a US population. Thank you. And the floor is yours, Kai-Hua.
Great, thank you for the nice introduction. Hello, everyone. Today, I'm going to talk about anticoagulants and all-cause mortality among hospitalized COVID-19 patients. Just want to make sure I turn on my camera here. Oh, okay. Can you see me now?
Yes, very well.
Great, thank you. It's my great honor to present on behalf of our all courses here. So this work was funded by Optum Epidemiology, and all the courses are over at the time of work employees at Optum and may all start from UHG. As we all learned that coagulopathy was the common features of severe COVID-19 cases, and it has been considered as a poor indicator of prognosis. There were a lot of studies has been confirmed to investigate the association between anticoagulation treatment on mortality in COVID-19 patients. And however, the results are conflicting. And also we know that the dimer, elevation of the dimer levels, it's a very typical patterns or components among the patients of COVID-19 associated coagulopathy. However, very few studies to looking at the association by the level of the dimer. So in our study, we aim to investigate the effect of anticoagulation on all-cause mortality in patients hospitalized with COVID-19, overall and stratified by the dimer levels. We use the Optum COVID-19 database, which is a subset of the Optum EHR data source. It is a very low latency database. It was updated fresh bi-weekly in the early time of pandemic and lately about bi-monthly. So this subset of data set include patients with some COVID-19 indicators. Either the patients have a suspected diagnosis or a confirmed diagnosis, or have a lab test of COVID-19, or have symptoms associated with COVID-19. So this data set includes a large number of data elements, such as demographics, diagnosis procedures, or different medications from administration or prescribed orders or patient-reported medications. Most importantly, we will be able to map to over 500 lab results and has a large number of bedside observations that allow us to assess to any information associated with COVID-19. So this study was a retrospective cohort study within the time window from the early 2020 to the late year of 2020 by November 30. So the study population include patients hospitalized with COVID-19, and they were identified using either a diagnosis code or a positive lab test result. We also require patients to have at least 6 months of baseline period prior to the cohort entry, or if patients have a prior history of critical care or mechanical ventilation, or have a diagnosis of thrombotic events during the baseline period, were excluded as well. To determine the use of anticoagulants, we use this list of generic drugs to define the use of anticoagulants, and also define the index day as the day they first use anticoagulation during hospitalization. We also calculate the days since admission. That was the days from the admission to the first anticoagulant use. This day since admission was used to define and determine the index day in the unexposed group. So that was the admission day in the unexposed group plus the randomly days since admission from the exposed group. So our study outcome was the all-cause mortality. They were identified using all follow-up data available. That means it's not just the deaths within the hospitalization. It also included deaths up to discharge. So it's regardless of the discharge status. So we identified this from the Social Security death master file, or they were indicated or recorded in the medical records. So the baseline characteristics were ascertained during the 6 months baseline period or on the index day. So included demographics, comorbidities, patient-reported medications, and also the top 30 frequently diagnosed procedures or prescriptions. We also looking at the D-dimer levels in a very detail stratified by different levels, and we only focus on the first recorded D-dimer levels after the admission using the DDU. So we quantified the association between anticoagulants and all-cause mortality using the relative risk and confidence interval, adjust for the trimmed IPTW. We first fitted a propensity score using the baseline characteristics and logistic regression with a stepwise selection. And then we trim the unoverlapped extreme propensity scores and calculate the stabilized weights using the formula. So we fitted the weighted odds ratio using the logistic regression and then converted to weighted relative risk. So this flow chart shows the study population, and the green color shows this is a data source. Within the study time window, there were about 3 million people in the COVID-19 database. And after we applied our confirmation criteria to define the COVID-19 patients, the number dropped down to 393K. And then the orange box shows that's the target population in this study. And we apply our eligibility criteria and also require patients to have at least one hospitalization inpatient visit. The number dropped down to 43K. Among them, about 88% of patients receive anticoagulants and corresponding to a 14.9% of mortality rate. And the rest 12% of patients not receiving any anticoagulants and corresponding to a mortality rate of 16%. So this table 1 shows the baseline characteristics by anticoagulant use. This is only include a selected list of our baseline covariance. We have many more variables. As you can see, this is the proportions between those groups are quite similar. And although we do observe a slightly higher proportion among the some comorbidities among the those who receive anticoagulants, but generally they are quite similar between both groups. And this table shows the estimates of the association between anticoagulants and all-cause mortality among patients hospitalized with COVID-19 overall, and also by stratified by D-dimer level. For the D-dimer level, we're looking at the cutoff point as 250 DDU, and any level lower than that will consider normal. And we're looking at the level by 1 to 2 times, 2 to 3 times, and 3 to 4 or greater than 4 times the normal limits. So as you can see, overall, we observe an inverse association between anticoagulants and all-cause mortality. We point estimate as 0.91, but this mortality benefits was not observed in the D-dimer levels lower than 1,000, only within for the patients with a very high, 4 times higher than the normal limits of D-dimer level. So the point estimate is about 0.82. So in conclusion, our study suggests that patients hospitalized with COVID-19 who received anticoagulants had a lower risk of all-cause mortality than non-users. And was the overall estimates. But then we stratified by the dimer levels, and this benefit was only observed among patients with 4 times higher dimer levels. Of course, this conclusion should be interpreted cautiously, and with these limitations should be taken into account. First is the data lag, because we use the DAS master file to identify DAS. As we know, DAS master file could have a long data lags. But at the same time, we supplement the information from the recorded DAS event from medical records. But either way, we will still run into the potential of underestimate the DAS event. And also the other big limitation is that we couldn't identify the hospitalized deaths because we only get the information, the death day as death month, not the exact death day. So we extend the death event to any death events with all data available after the hospital admission or the index date. That will be the first anticoagulant use. The another thing is for information, if a patient seek the medical care outside of the wider network, we wouldn't be able to get the information. This will be true for a lot of the medical comorbidities or other baseline information as well. And also want to point out the hospitalization could be misclassified because we do notice some patients have either missing admission day or missing discharge day. In our study, we focus on all those with a clear admission discharge day to divide the hospitalization. So that's all, and I would like to take any questions.
Thank you very much. So now the floor is open for questions. If anybody would like to ask anything, please enter the question on the chat and we will be happy to read it for you. I may have one question. In one slide, you present us the population included in the study, and I noticed that you have relatively young patients with COVID-19 on anticoagulants. Could you comment a little bit on that? If I read the slide correctly, I believe you have persons between 10 to 19 years of age on anticoagulation. What is up? Can you describe those patients? What type of comorbidities would they have?
Yeah, we have about only a couple for those younger than 19 years old. We have about like 130 patients.
Mm-hmm.
Yeah, we didn't looking at that specific stratified by that age group. But I think in a future study, it would be good to looking at those with the adult use and those with pediatrics use to see what the estimate was changed. But because of the number about those younger than 19 years old is really small. So, yeah.
Yes, my question is also keeping in mind how the epidemiology of the disease is evolving, where we are seeing more cases among younger persons, and would be interesting to understand a little bit more whether those patients are on anticoagulation or receive anticoagulants for other reasons. Thank you very much. And I think we have a question on the chat. And Frederick is asking, I think you can read it as well. Would you agree that the results are similar across the 3 highest D-dimer groups? The protection estimates are relatively similar to each other and the overall, and the fact that levels 3 and 4 are not significant are likely mainly because you have split the data into smaller groups. Could you comment on that?
Yeah, so I think that could be a possible because when we're looking at those with only D-dimer, for the patients with D-dimer level recorded, in our overall data, we only have focus on 36 to 40% of patients with those information. It is possible that the not significant result will be due to the small sample size for those strata levels. But the another interpretation could be because we only looking at all the mortalities and not like a 30 days mortality after admission or hospitalized admission. So it's possible some patients with a more severe disease, they have the death event close to the admission day, but those with a less severe disease have a death event could be longer. But in our next step, will be very helpful to looking at all those duration from the index day to the death day, if we will be able to get that information.
Mm-hmm.
Thank you for the
very
great
much.
questions.
Thank you. Thank you, Frederick, as well for the question. Do we have any other questions from the audience? If not, I think we would like to thank you again, Kaiwa, for this great presentation. And again, a very nice order of presentations. The organizing committee did very well. I think every time we are adding one additional element to the story of anticoagulation in COVID-19 patients. And I think now we can go to the next presentation. Thank you.
Great, thank you.
Excellent, thank you so much. So I'm going to introduce our next speaker, who is Julien Bézin of the Université of Bordeaux. And his talk is entitled Use of Cardiovascular and Anti-Diabetic Drugs During COVID-19 Epidemic in France. So welcome, Julien, and I confirm that we can see your slide deck.
Okay, perfect. Thank you.
Thank you.
Thank you. So I will present a study that has been conducted in the pharmacoepidemiology unit of Bordeaux in France. And so this study is about use of cardiovascular and anti-diabetic drugs during COVID epidemic in France. Okay. So this is my conflict of interest statement. This study is part of the Drug Safer research program funded by the French Medicine Agency. As you certainly know, in this pandemic period, patients usually treated for chronic diseases have fast difficulties in accessing care, whether voluntarily or involuntarily. To face the pandemic wave, patient population were isolated and care focused on the management of COVID patients. So the major fear concerning non-COVID diseases related to interruption or delay in care and the consequences on patient health. The implementation of the first national lockdown in France has been accompanied by a questioning of patients about the supply of drugs, as we can see on the Google Trends for the search of open pharmacy at the right. In France, the epidemic started on February 2020. To face the epidemic wave, a national lockdown was decreed on March 17, 2020 until May 10. Organization reacted to limit the consequences of this necessary measure by accelerating and facilitating the development of telemedicine where possible, and by facilitating the extension of drug dispensing to prevent for treatment gaps. Consequently, before to estimate the potentially associated health consequence of such, we aim to assess the effect of the COVID-19 pandemic on cardiovascular drug prevention in France. To meet this objective, we performed a study using data of the French National Healthcare Insurance System for the period from November 2018 to September 2020. SNDS linked with the National Hospital Discharge Database contain information for all the French population. This database contains individual anonymous information on socio-demographic data, reimbursement of care, including all outpatient reimbursed drugs, and medical data combining information for expensive long-term disease and for hospitalization. Using this data, we conducted a weekly repeated cohort study. For each of the studied week, patients were eligible if they had been affiliated to the French health insurance system for at least 1 year before the week starts, and if they were alive on the first day of the week. We considered all drugs used in cardiovascular prevention, whether used for cardiovascular ischemic diseases prevention or for the prevention of thromboembolic accidents. The drug classes of interest are therefore the pharmacological classes corresponding to lipid-lowering agents, antihypertensive, antiplatelets, oral antithrombotics, antiarrhythmics, and anti-diabetic agents. Exposure to each individual drug of these classes was estimated using dispensing data. For each dispensing, the period of treatment covered from the dispensing date was set as 30 days or 91 days for quarterly packages, to which a grace period of 5% was added. Weekly prevalence of use corresponded to the number of patients with ongoing treatment episode for one drug of the drug class during the week of interest. Weekly incidence of treatment initiation corresponding to the number of patients for whom a reimbursement of a drug of the class was identified during the week, and no prior dispensing had been over the year prior to the week of interest. Weekly incidence of treatment disruption corresponding to the number of patients for whom the last identified treatment episode terminated during the preceding week and no dispensing was identified over the week of interest. We used an interrupted time series design to assess the impact of the COVID pandemic and associated measures on the utilization of these studied pharmacological drug classes. An observed component model method was applied to predict use of drugs and compare it to observed use after March 2020. More than 25 million patients met the inclusion criteria. Women accounted for 57% and mean age was 61 years. The most frequent comorbidities recorded as severe long-term diseases among the considered affiliates were diabetes for 13%, cancer for 9%, and cardiac disorder or coronary heart disease, both for 6%. We observed a recurrent pattern in this study concerning the data on drug dispensing in France, whatever the drug class studied. As this session is about antithrombotics, I focus our results on these drugs. As you can see on this figure, the number of subjects having at least one dispensing is very strong decline during the new year, whether in 2019 or 2020. When we focus on the lockdown period, we observe a big spike in dispensing when the restrictions were announced in France. We have noticed a stabilization of healthcare consumption for almost 2 years for most of the drug classes studied. However, for antithrombotics, we were able to see an increase in direct oral anticoagulants and a decrease in vitamin K antagonists. Moreover, when we focus on the lockdown period, in gray on the figure, after the spike in dispensing when the restrictions were announced, we observed a slight decrease during the weeks of lockdown and a slight increase when lockdown was stopped. Based on the time series prediction, we find that dispensing for all drug classes had declined from 1 to 4%, smoothing out the spike in dispensing at the beginning of lockdown and the decline in dispensing throughout this period. This was based on the comparison of the observed data during the lockdown period with the predicted data for the same period using the previous month's data. Treatment interruptions were impacted by COVID period. Regardless of drug class, we observe an increase during the lockdown period compared to 2020 predictions. Cardiovascular drug interruptions were very significant outside of antiplatelet with 3% increase. For example, the number of subjects with discontinuation of direct anticoagulant increased by 70%. These interruptions were more limited for antidiabetics. We also observed that the proportion of subjects who initiated cardiovascular treatment decreased during the lockdown period and even decreased considerably for antidiabetics. We recorded a decrease of more than 30% in the number of patients who initiated antidiabetic treatment between the lockdown period and the same predicted period, except for insulin with a drop of 12%. The number of subjects initiating cardiovascular treatment was still impacted, also the decrease was less significant. For example, antithrombotic treatment were initiated less by about 20%. Strengths and limits for this study were mainly due to the database used, which contains the entire French population and is exhaustive regarding outpatient care dispensing. But this database contains no information about the real drug intake, cause of drug interruption, or drug indications that make the etiological interpretation of this result difficult. Indeed, on the one hand, the interpretation might not have occurred if the patient had stock of drugs at home, and on the other hand, the decrease in initiation might be in line with a decrease in cardiovascular events over this period. In conclusion, the COVID-19 epidemic and its consequences on healthcare organization has destabilized the cardiovascular and antidiabetic drug uses in France. The stockpiling phenomenon was observed just before national lockdown. Even so, treatment interruption increased over the lockdown period as compared to forecast, and treatment initiation were found lower than expected. the health consequences of these treatment discontinuities and lack of initiations remain to be evaluated. Thank you for your attention. And if you have any question.
Great, thank you so much, Julien, for an interesting presentation that also highlights essentially the very important impact that the lockdowns had on whether or not patients initiated or continued treatment for primary, secondary prevention, right? So very important. So again, I invite our audience to basically type in their comments and questions in the chat box. So I was wondering if you, and I will again start with my questions. I was wondering if you could potentially please help, just help me kind of understand what it was that you had done. So, or the methods in a little bit more detail. So it sounds like essentially for some of your analysis, what you did is essentially you looked at, whether or not like on a weekly basis, whether or not the patients are initiating or discontinuing or interrupting their treatments, right? And then you looked at it essentially at an ecological level, right? So where you did the interrupted time series to essentially look at whether or not the patterns were changing kind of before and after the lockdown. Is my understanding correct?
Yes, absolutely. Just 1 minute, I open the light because I'm in the dark.
Yeah, it's very dark.
Sorry about that.
No worries.
Yes, it's correctly that we defined a weekly based cohort. Each week we constitute a cohort and we calculated if the patient dispensing or initiate the drugs or interrupted the drugs. Yes.
Okay, excellent.
We model this by time series analysis with UCM models.
Okay, excellent. Thank you for clarifying. I was also going to ask, so something that you showed that, popped up on a lot of your figures is essentially this, whatever happens essentially around New Year's. So is that, so where essentially the utilization of prescriptions basically go to zero? I'm assuming that's just due to a general kind of shutdown around the holidays in France. Is that correct?
Well, yes, it's that I think I don't have the real explanation, but we identify a stock before and a stock just after the New Year. So we hypothesize that during holidays for the New Year, patients don't go to pharmacy and take drugs just before or just after this week to their medication, and there is no gap in treatment continuities.
Well, what's interesting, from that figure is that you didn't observe any stockpiling, which, right? So because, during the lockdown, what it is that you observed in the curves that you showed and the graphs that you showed is essentially an increase in the dispensations, right? But you don't see anything, to that effect at all, like during those periods where essentially the dispensations go down to zero around the holidays. So which I thought was somewhat interesting. So in terms of stockpiling, I was wondering if you could explain a little bit more about how you define stockpiling. So is it just going like more, actually just, yeah. So is it going earlier to the pharmacy before? Yes. Yeah. So yes. If you have, and essentially that a patient has like a 30-day or a 90-day dispensation. And so what you're seeing is people just filling in their prescriptions early.
Yes, it's exactly that.
Okay. And then another question regarding what was also surprising to me was that immediately after, the lockdown, what you see is no bounce back, right? You see essentially the very kind of similar patterns that you were essentially seeing before the pandemic, right? So can you comment a little about that? I would have expected that we would have seen a little bit, maybe kind of an increase, right? I understand that some patients, are not filling their don't go fill their prescriptions or discontinue, but I would have still expected a little bit of higher dispensation activity after the lockdown.
Yes, we hypothesize these two. I think there is a really gap in drug dispensation during the lockdown, and the patients don't take correctly their drug during the lockdown. And I don't have any explanation because we don't have patients in the study. It's only drug reimbursement. So I think it's that, but I don't know if it's true.
Yeah. Okay. And then I guess you had also, you know, as a potentially as a next steps. So I thought essentially with the data set that you had, you also had information. So you could also have information essentially on patient outcomes, because the next logical step would be, you know, look, you know, patients are, you know, not been filling their medicines, they've been discontinuing them, they haven't been initiating them when they should have, and this is essentially how it's impacted patient outcomes. Or is there any are you interested potentially, or is your group interested in exploring, or are you exploring that question, that particular question?
Yes, absolutely. We want to identify if there is a consequences on cardiovascular prevention, so myocardial infection, strokes, or any acute outcome. So we have hospitalization data for that. So yes, it's the objective.
Okay, so you're already on it.
Yes. Yes.
Okay, excellent. Well, if there are no questions from the audience, you know, Julien, thank you very much for your time and for your very interesting presentation on another unfortunate impact that the pandemic has had on patients in you know, in the world and in France. So appreciate your time. And so Montse, I will pass it back to you to moderate for our last speaker.
Thank you, but if you allow me, I would like to ask a question to Julien. I didn't know whether I should put it on the chat or just ask. I will be brief. Julien, you have data that covers the whole country. So you have a unique opportunity to potentially change policy. Are you planning to share, or are you already sharing these results with authorities, health authorities in France, and potentially, especially when you start looking at consequences of all these levels of disruptions, because that could actually guide decisions in trying to avoid this type of crisis situations in healthcare systems in the future. Very few data sources, I think, would allow for that magnitude and volume of population being covered to potentially guide some decisions by policymakers.
Yes, absolutely. It's a very good question, because this study was conducted with the French Medicine Agency. So results will be communicated soon to the agency, complete results. And we make, I think, a discussion with health authorities with these results. Thank you. Thank you very much.
Thank you very much. Thank you. And Aisling, apologies for not going straight to this next presentation. So it's nice having you here. I'm happy to introduce Aisling Caffrey. She works at the Infectious Diseases Research Program at Providence Veterans Affairs Medical Center. And Aisling is going to tell us about heterogeneity in the management of hospitalized patients with COVID-19. Thank you.
Thank you so much, Montse, and thank you to Jessica and actually all of the speakers. This session, I mean, it's so complimentary, these talks. I think I have points that will touch on things that Albert, Benjamin, Christopher, Kaiwa, and Julien covered. So I'm going to hopefully point those out as I'm going along. I hope everyone's having a great second day of ICVI, and I'm going to present some of the work that we looked at in terms of treatment heterogeneity and hospitalized COVID-19 patients in the VA, actually. So actually a lot of this work that my team and I have started many years ago in infectious diseases was looking at treatment heterogeneity in bacterial infections. Some interesting points about that is that treatment guidelines exist for a lot of bacterial infections, and we're looking at serious bacterial infections with substantial antibiotic resistance resulting in hospitalizations. And when we went to sort of look at comparative effectiveness and comparative safety research and trying to identify these patients exposed to what treatment recommendations would indicate, it was actually very rare we found patients that met these criteria of treatment recommendations. And instead, when we started looking at heterogeneity, and in the presentation, I'll show you exactly what I mean by heterogeneity, we were actually seeing substantial heterogeneity in the treatment, again, of these bacterial infections that have treatment recommendations. So in the area of 80 to 90% of patients are treated differently. So with different antibiotics for different durations in different orders of administration. So here comes COVID. Oh, sorry, so I'll back up a little bit. Disclosures, this presentation, the materials are not the position or policy of the United States Department of Veterans Affairs. The study was unfunded, and these are our conflicts in terms of industry funding and speaker consultancy. Right, so now fast forward to in infectious diseases, again, antibiotic-resistant bacterial infections, we've already seen substantial heterogeneity. Again, these are with pathogens that have been around for ages, and we're still trying to figure out how to best manage them. So here comes COVID. Of course, we're all asking, how do we best manage these hospitalized patients with serious life-threatening COVID infections? And then, of course, as Albert showed in such a great, fun way, treatment recommendations, not just treatment recommendations, but treatment practices were changing frequently based on emerging science, or as Albert was showing, non-science, and the pressures of the times, I would say. And so, right, so it was sort of day to day, sometimes week to week, and you know, the amount of scientific evidence, I don't know who could keep up with it. I sure as heck couldn't. But for different treatments, thank goodness for the fellows, when we were doing this study, and they would say, oh, wait, something new. People are using something new, maybe. And so trying to keep up with that. So of course we were expecting, when we started to look at this, substantial treatment heterogeneity. Maybe not necessarily treatment for COVID, but just how are we managing these hospitalized patients? What the heck are they even getting in the hospital? And to look at try to identify some patterns there. So again, you know, if we're going to even get to the points of talking about real world evidence for prevention and treatment of COVID, we really need to understand how patients were being managed in this inpatient setting. So the objective is to quantify the heterogeneity of medications received by patients hospitalized in the national VA healthcare system. The data source were, so very early on in the pandemic, the VA developed curated COVID-19 databases, but we actually used the databases we normally use, which are the national databases created from electronic medical records. So the population included hospitalized veterans with positive COVID-19 PCR tests from March 2020 until November 2020. I will say this is an ongoing study. So when we did this analysis, it was based on this kind of data. We then conducted exposure mapping. So that's where we literally take all the medications a patient receives on each day of the admission, and look at what they were receiving. I'll talk a little bit about what the index date and period that we looked at, but we started, this list is actually even larger now, but we started with 136 medications, which included potential COVID-19 treatments, chronic disease medications, and then common medications used in hospitalized patients, such as anticoagulants, and then also antibiotics. So the area that I come from is looking at antibiotic utilization, overuse of antibiotics, and so forth, and appropriate use of antibiotics. Again, so we assess treatment patterns. So by drug and duration. So, you know, did patients get anticoagulants for 3 days in a row versus 4 days in a row? Did they get anticoagulants and antibiotics for 3 days, then only anticoagulants for 3 days? And so that's what we were talking about with drug and duration. We also then took out duration and looked at drug only. So were patients getting anticoagulants and antibiotics? And then we did it by drug category. So we looked at it by actual drug. So if they were receiving, for those of you who have been following it, sort of azithromycin was being used earlier on, and then it switched more to ceftriaxone, and then we've seen changes in that. So we looked at it by specific drug, but then we also looked at it by category. And heterogeneity just means that these are patients who had different patterns in any of those. So the drugs and the duration, the drugs that they were receiving and the order in which they received them, and then drug categories in the order in which they received them. So heterogeneity indicates these patients had different patterns of what medications they were receiving. I will note, so we didn't look at fluids, just that's one note. Okay, so our patient population. So again, with this cut that we had for this abstract, it was 16,000 patients in the VA. For those of you who are not familiar with the VA healthcare system, our population is predominantly older white males. Hence, one of the limitations I'll mention at the end is limited generalizability to sort of community settings. The great part, so unlike with Julianne, who is talking about national data on prescriptions, the United States doesn't have a nationalized healthcare system. Our information on health, hospitalizations and healthcare the systems are very disjointed. Whereas in the VA, they're very connected. And so we get the spectrum of care for these patients. We have the care they were receiving before hospitalization, very specific information during the hospitalization, and then care afterwards. You'll see that about a third of our patients spent time in the ICU. The most common admission source was outpatient, and their most common admission service was medicine. So they essentially initially came into a medical floor, and then, but about a third ended up in the ICU. So if we look at treatment heterogeneity, and these are just some of the measures we look at initially to look at treatment heterogeneity. So about 88% of patients had changes in the types of medications that they were receiving during the hospitalization. So the vast majority, about 12%, had no change. If we look at the day of change, so that would have been from the index date. And so the index date was either the hospitalization date, it was the first of the hospitalization date, or the first positive PCR COVID-19 test within 3 days of admission. So we wanted to include those patients who may have been in the ED testing positive and then getting subsequently admitted. So the day of change was day 2 from the index date. The median number of changes was 3 changes in therapies that they were receiving. If we look at unique change patterns with length of therapy, there were 98% different patterns. And if we look at drug and duration of drugs. If we look at change patterns, unique patterns without length of therapy were about 94% different. If we look at those who did not have change in therapy, so they stayed on the same set of medications for the entire hospitalization, we see that there is still pretty large heterogeneity when we looked at duration and drug, which was 49%, and it was lower if we just looked at drug, 30%. Here are some of the common medications. This is essentially the presence of at least 1 day of these medications. This does not account for duration at this point. I will show some another slide that depicts duration. So anticoagulants were the most commonly administered group of medications. So 93% of patients during that hospitalization, so of those 16,000 patients, had at least 1 day of an anticoagulant. Commonly, patients actually stayed on their maintenance medications. So we had about 56% on statins. Again, of course, the corticosteroids, which we saw, we actually have a separate poster about this, but we saw changes in these treatments over time, of course. So corticosteroids were lower and now they're much higher. I was actually trying to grab some of the percentages. I think it's up to 70% now. And sorry, that was the end of September and October and November of 2020, sorry. Antibiotics, were about half of the patients are getting antibiotics. Again, there's a lot of controversy about whether they should be getting antibiotics. If we look at aspirin, about 40% of patients are getting aspirin. And again, this is in the hospital setting. Melatonin was about 30% of patients. Hydroxychloroquine was initially high, but quickly went very low. Thank goodness with emerging evidence, and on our very vulnerable population. Let's see, remdesivir, which is now actually the leading treatment in the VA for COVID-19, is about a third of patients overall from that March to November timeframe. And then immunosuppressants, some of these other ivermectin, we had actually very low percentages of the IL-6s and the JAKs. Let's see. So if we want to break down what the most common medications were within some of these more common drug classes or categories, we can see that enoxaparin was the most common with 65% of patients, followed by heparin. The DOACs were uncommonly used, which is typical of in the VA. If we look at statins, it was about 40%. Atorvastatin, again, reflective of in numerous cohorts that we look at of our VA patients, atorvastatin would be the leading statin. So it follows essentially what we would expect. Corticosteroids, the majority were dexamethasone. And then with antibiotics, we actually saw an interesting, right, so we all heard about the azithromycin initially, and we were expecting to see declines in the use of azithromycin. That's actually remained relatively stable. Then we saw this increased use of ceftriaxone, and then we actually saw it decrease. So, but again, about a quarter of our patients overall from that March to November timeframe received azithromycin and ceftriaxone. The other antibiotics were less commonly used. So if we look at the course of the admission, so again, most patients, is about 60% of patients, the admission date and the test positive date were the same day. And then so a smaller percentage were actually mostly then would have been the day before, and a very small percentage on days -2 and -3, essentially from hospital admission. But so day 0 is the index date. So that's again, hospital admission day or first test positive within 3 days of admission. So here we can look at what patients are initially started on. And these would represent percentages of how many patients are receiving these medications. And so, like I mentioned, about 93% received an anticoagulant. Enoxaparin was the most common. We actually see that little bit of a lag in the increase from day 0 to 1, but then we get that larger percentage of patients by day 1. And actually the percentage of patients on the medication on enoxaparin increases actually towards that 14-day mark. Similarly with dexamethasone, we actually see that the increase in utilization actually gets to be sometimes that later period, so that 4-day mark, even 5-day mark. These patients are in maintenance medications. We actually see some lower initial estimates, and that may be just because of the severity of the patient at the time. And then once they stabilize out, that they reinitiate that atorvastatin. Remdesivir, we expect to see that, we were trying to actually initiate remdesivir early, but we see that sort of 1-day lag, and then you see where it actually makes up a greater percentage in those days 1 to 5, 1 to 6 timeframe. Heparin, again, we sort of see initially it remains a little bit lower, actually decreases in this 2 to 5-day range, 2 to 6-day, and then increases again towards that later end of the hospitalization. Azithromycin early on and then decreases, prophylactic perhaps, and similarly with ceftriaxone. The limitations are that treatment recommendations in COVID-19 epidemiology was rapidly changing. Actually, unfortunately, as in many populations here in the United States, Black veterans were disproportionately affected with COVID-19 early on in this pandemic. We saw that decrease somewhat in 2020 towards the later part of 2020. But if for the number of Black veterans that were affected, it was not representative of the actual distribution of Black veterans in the VA population. So the epidemiology of the patients affected by COVID-19 in the VA changed over the course of this pandemic, as did how well we were managing patients, and so mortality rates and such. And so this analysis doesn't account for any of that. And then, of course, the limited generalizability to the community setting. Conclusions are that there is substantial heterogeneity in the management of COVID-19 patients in terms of potential COVID-19 treatments, other medications used, clinical management in the hospitalized setting. And the complexity of medication management must be assessed and controlled for as we search to identify possible preventive therapies and optimal treatments for COVID-19 and associated drug safety concerns. Especially if we're looking at some of these immune modulating impacts of medications patients were on prior to developing COVID or contracting COVID, we're going to have to take into account this heterogeneity and how patients were actually managed then once they develop COVID. So thank you, everyone. I'm looking forward to any questions that folks have.
Thank you, Ashley. Yes, we have time for a couple of questions, but I don't see any questions on the chat. If anybody's interested, please type your question and we will read it. I have a question. I'm not sure that there is an easy answer to that. When I was looking at your slides, I kept thinking, could this be done at the time when some of the survivors of COVID-19 may or may not be experiencing some long-term effects associated with their illness, whether it's cardiovascular conditions, renal conditions, etc. Is there a way in which perhaps one could follow up those patients, COVID-19, and then look at their treatment patterns 6 months down the line, 1 year down the line? I guess we will be learning a lot about how physicians are also going to try to learn how to manage some of those conditions.
Oh my gosh, absolutely, Monse. With this data, with COVID-19, I feel like there are unending questions, and there's so little time to answer these things. But I mean, so absolutely right. So we want to see, so that's a great question coming from the chronic disease perspective. We're really interested too from the infectious disease perspective. What is the infection risk so talking about long COVID, we don't even have a sense of, also then infection risk and what does that look like? So we've seen, for example, influenza disappear, great. I mean, we'll see what happens. But what about these bacterial infections? We don't have a good sense of what's going on, with those infection rates and drug resistance and being in the hospital for so long. So yeah, there's a lot of questions that we still have to look at. How are they managed? And then what happens afterwards? And then what new diseases do they have or conditions do they have? And did they then, get over COVID and develop some other chronic condition or develop some other infectious condition that's going to require long-term treatment? So I think it's as an infectious disease pharmacoepidemiologist, it's a super interesting time because there are so many questions to be answered, but obviously devastating time at the same time that, we, again, in infectious disease epidemiology of pharmacoepidemiology, we knew this was a possibility, but I didn't expect it in my lifetime. So.
Thank you for that. There's a question from Benjamin. The question reads as follows. Would you be able to comment on the 1/3 of patients of cohort within the intensive care units, potentially age-related?
Oh, potentially, right. So we haven't even gotten into all of that yet, but absolutely right. Do you know what, interestingly, and I gave a talk about it also. So we're seeing this interplay with age and obesity. So we were seeing very disproportionately affected negative outcomes in our obese populations. And when we would look around the ICUs, we were seeing that a large proportion were also obese. And then that carries in all sorts of other factors in terms of other chronic conditions also.
Thank you, Ashley. I don't see any more questions from the audience. I am actually very impressed on how well we all manage in keeping the time. I've never seen anything that well done and with no technical issues in addition. Thank you very much to all the presenters. I mean, you have done a great contributions to understanding this pandemic. And this morning in other sessions, you may have attended as well, there was discussion on poor quality research, especially in the early stages of COVID-19, of the pandemic, and how pharmacoepidemiologists have struggled having to see sometimes poor studies being conducted. I think today we saw a series of very high quality research being presented in these sessions, very impressive. And again, addressing very critical questions, which hopefully will help us in preparing for potential future public health crisis, which we should still be prepared for. But in any case, very, very important, the contributions by everybody in the group of presenters. Thank you, Jessica. It has been great moderating with you. We never met before, I think. And thank you for this audience who has been able to stay with us for the full duration of the session, late in the evening in Europe, in the middle of the night in Asia, I guess. And Jessica, I don't know, maybe you have some final words from your end as well.
No, I think you really summed up very well. I think the essence of this session, it has been very nice to meet you, to moderate with you, and also meet our speakers and moderate. They're very, very interesting work and great contributions. And I have nothing further to add. Just wishing everybody wonderful, rest of the second day and third day of ICP, and looking forward to meeting everybody in real time and in person, maybe in this subsequent year or years to come.
Thank you. Thank you, Jessica. Thank you, everybody. And thank you to the audience for staying with us. Bye-bye.
Bye-bye.
Thank you. Bye-bye.
Thank you.